I hope everyone had a good lunch. Got to see many of you, so it was great to have that break. And thank you for, again, being here. I know we have a lot going on this afternoon with additional panels, and feel really fortunate that I get to be here with Nancy Ann. And as the voice of God shared, Nancy Ann was former administrator at CMS and also served as healthcare advisor, head of the White House Office of Healthcare Reform during the Obama administration, but also has experience working in state government in Tennessee, and also is at Consonance Capital now, focusing on healthcare investment and innovation. And this, on the day of open enrollment, also gets to be a full circle moment because Medicare Plus Choice was signed into law in 1996. And you were at CMS then or not?
1997.
Okay.
And I was, at the same time it was signed, I was confirmed as the new administrator. So.
Okay. She had been at OMB earlier,
yes.
and I was fortunate to have been at the department as the deputy chief of staff at the time. So when I came to BMA 5 years ago, it was a full circle moment to be able to come to the Better Medicare Alliance, focus on Medicare Advantage, and so just. Now I'm really dating us because now it's over 30 years ago, and that wasn't the intention, but to be able to be here and talking with Nancy Ann now about Medicare Advantage. And so just recognizing that, Nancy Ann, what you've seen, I just sort of want to do a kickoff question, somewhat big picture. What you've seen in the healthcare system during this life cycle of Medicare Advantage, what do you see as the value of MA to seniors when we're trying to prioritize affordability and quality of care? And I'll sort of focus first on the value of it, because obviously I do want to do a follow-up on where, as we had talked with Dr. Oz, both about value of MA, but also where we need to strengthen the program. So kicking that off.
Thank you for having me here today. You know, it is a full circle moment, and especially it's great to be with a group of people who spend every day thinking about how you can make the health care and the lives of seniors and people with disabilities better, because I know that's what you're doing. I love this organization. I think it was founded when I was still in the White House, or right as I was leaving the Obama administration. So Medicare Advantage, as Dr. Oz said, is somewhat young, and this organization is very young. But I think it's so important to have a group of people who are focused on strengthening and improving the Medicare Advantage program. And seeing those seniors that you focused, the beneficiaries who were here, actually, I don't even know if they are seniors, you know. And all I can say is when I was CMS administrator, and let's really go back and be honest, it was called HCFA. I see a lot of young faces. There's a few people are admitting to knowing what that was in the audience, but when I was CMS administrator, I did a lot of traveling around the country, and I insisted that every time I took a trip, I spent time with beneficiaries. I had a meeting with beneficiaries, and seeing them up here talking about the benefits of Medicare Advantage, it brought me back to those days of sitting with seniors and hearing them talk about their health benefits. And I have to tell you, you know, it was around the time Medicare Plus Choice was kicking off. Some people were in some risk plans. There were a few of them around the country, but it wasn't very big. And so what I heard from them was, I need prescription drugs, and there's no Medicare plan in my area. That was the only way you could get it back then, you know? I'd like to get preventive benefits, but Medicare doesn't cover it. You know? And they always said, as these beneficiaries said, you know, please, if you see the president, tell him I said thank you for Medicare, because without Medicare, I'd have nothing. So they were always grateful for what they had, but it wasn't what they have now, thanks to what you all have brought to them. So thank you for that, and thank you for having me. When I think back on the almost 25 years since this program started, you know, it was a few million people back then. People asked me, did I think it would get to be this big? I wasn't sure. I thought it had the potential to be big, as Dr. Oz said, to not just crawl and walk, but to run and fly. I thought it had that potential. And the reason I thought that was because of the time I spent with seniors, talking to them about what they needed and what they wanted. And they wanted access to prescription drugs. They wanted more affordability, and that's what this program has been able to deliver. So in that way, I think it's really, truly been amazing.
Thank you. And actually, what stuck with me when Dr. Oz spoke, and you're on the same theme, is recognizing the affordability of the program and the quality of the care. And so when we keep putting this program with the focus of seniors up front, it's, how do we retain that, keep stability, but then at the same time, and you spoke to our mission, we need to protect the program, we need to strengthen it. So on the strengthening side, what do we do to continue to improve it, but not lose that affordability and quality that you just spoke to?
Exactly, and I guess I should also say, you talked about my background in the public sector as the regulator of Medicare Advantage, and at the White House later with the Affordable Care Act. But I've also been on the other side of the table as a part of a founding group of a Medicare Advantage plan called CareMore that ended up becoming part of Elevance. And then until recently, I was on the board of CVS and Aetna. So I've been on your side of the table as well, some of you who are in health plans. And what is sometimes missed in talking about even I applaud the congressman who was talking about the apples to apples bill. I'm in favor of looking at that. But what's sometimes missed when people are doing the regression analyses, and Dr. Fendrick, where are you? You were here somewhere. I apologize if I'm messing that up, but looking at the cost versus a fee-for-service versus Medicare Advantage, they're not looking always at, or ever perhaps, at the regulatory capital that goes into having a plan. Are there any actuaries in the room? I mean, if you know that your actuaries are the ones who are looking at the beneficiaries who are coming in, who are saying, we need to know what their conditions are so we can decide how much it's going to cost to take care of them. Not just today, but a year from now, and obviously you want to have them for a longer period of time. You don't want them to be churning in and out. You want them to feel like they're getting what they need in your health plan. So I'm not sure that unless they've been in the business of healthcare, that the analysts who look at this are just looking at a point in time of, Rob Rasmussen when he was in fee-for-service versus Rob Rasmussen in Medicare Advantage in one given year. I don't think that's really what we need to be looking at. If you're looking at strengthening the program, are we looking at the long-term, the quality of life, the life expectancy of someone who's had access to the preventive benefits that he talked about? That's a good PhD program, Dr. Fendrick. If you
got an assignment there, Mark.
Got an assignment for one of your PhD students.
He's taking notes. One of the areas that, again, because I was just up here with Dr. Oz, I'll continue to reference, but it's along the themes of what you're talking about in the Medicare Advantage program, is that there's innovation that's central to it, but we need to retain accountability. And as you look at where the program is today, Nancy Ann, where do you feel it's been most successful in that area, and where do you think we need to go? Because again, we want to sort of look at both sides and where we need to improve.
Well, obviously affordability is a huge place of success, and if I heard one thing from Medicare beneficiaries back then, and I still hear it today, and you heard it this morning, it's affordability is key to them. That's a big part of what they're looking for. And yes, one man's affordability is another man's excessive profit, I suppose, if that's how they're looking at it. But when you're telling me that Medicare Advantage plans save, an average of $3,400 for a beneficiary versus fee-for-service, that's a huge affordability advantage that you're providing. So it's been a huge success there. I don't think we can stress too much how important Medicare Advantage has been in discovering, adapting, quickly moving forward or failing and jettisoning innovation in healthcare as well. There have been so many ideas, ranging from the prescription drugs to begin with, figuring out how to offer that coverage to seniors, to the preventive benefits, to incentives for seniors to take care of things. When I was at Caremore, one thing we did, and I know other plans are doing this too, is we did mental health clinics and group therapy for women in Los Angeles in a neighborhood that was mainly Latina. I went to, one of the things I loved doing when I was part of that plan was going to beneficiary meetings, and I got to go to one of their sessions, and some of them said they'd never had access to mental health services before. And so even if theoretically that's a service you have as a Medicare beneficiary, someone needs to take your hand and help you see, oh, this could be a benefit to you, to your health. And that's just not something that Medicare as a program with as many beneficiaries as it has can do. That's something that a health plan with navigators, with people on the ground can do. So those kinds of innovations are things just addressing social determinants of health, which is a thing now in healthcare. Where did that come from? That came from the work that all of you did and looking at, meeting the beneficiaries where they are in the communities and figuring out how to take them forward. I mean, at Caremore, we did something else. Maybe we weren't supposed to do this, but we went into their homes. This was, what year would that have been, like early 2000s. It was a doctors group that we made into a Medicare Advantage plan. We went into their homes and we went to their medicine cabinets with their permission and had nurse practitioners take out all the polypharmacy, which is a fancy word, as you all know, for having a lot of old prescriptions in there that you shouldn't still be taking. And sometimes people did still take them, and sometimes the prescriptions got filled and they shouldn't be. And it's a source of going to the hospital or figuring out if Mrs. Jones needs an air conditioner, that she might be back in the hospital for her congestive heart failure, but it wouldn't really be because of the congestive heart failure. It would be because of her apartment was 103 degrees. So how do we help her get an air conditioner? Transportation. That's not rocket science, right? But it's something that traditional Medicare just wasn't able to do. So it's almost silly to call that an innovation, but it was an innovation at the time. Now everyone realized, well, without access to the right providers, how is anyone ever going to get the preventive benefits? We have to provide access. So all of that's happened because of what Medicare Advantage has done, in my opinion. So it would be a shame to be so focused on a comparison with fee-for-service, which, by the way, and my friend who Mary Beth, Dr. Jeff Kang, who was the chief medical officer at CMS, HCFA, when I was there, wrote a paper a year or so ago about this, which is that the criticism of risk adjustment, and coding that we started talking about this morning in Medicare Advantage, fair enough to criticize it, but really the comparison should be that fee-for-service should be doing more. It shouldn't just be that you get into Medicare, you go into traditional Medicare, and that's it. Nothing happens after that. If you're lucky enough to have, Mary Beth Donahue or Nancy Ann DeParle as your relative, they can sit down with you and say, okay, we should go get this taken care of, or we should get that taken care of. But if you're like many seniors who don't have that person, what are we doing? So is that the model? Is that what we think is great? I don't think so. I don't think so. So should we be doing more for fee-for-service? Is it really that, why are we criticizing Medicare Advantage for doing more? And I've said for 20-something years, I said this back when I was at CMS, I'm willing to pay more if I'm getting more. So the issue is, how do we show that we're getting more? And I think Dr. Oz said something like that. He said, we want to pay you for what you're doing to preserve or to improve health. And there have been good studies that have come out on that. I wish there were even more, because I personally believe, it's easy for me to say because I don't have a PhD in statistics or health policy, but I personally believe that people live longer. I personally believe that if they get that care, they live longer. We know from studies that have been done of the Affordable Care Act that having coverage that is affordable gives people the psychological benefit quality of life that does extend their life. And I'd have to believe that's true in Medicare as well. So that's the crux of the issue, though, is how do we show the value that we're bringing to the table? And why are we holding fee-for-service to such a low standard? That's the other thing. It was as though we're saying that somehow is the model, because I don't think it is.
No, we couldn't agree more, and I think you hear us speak to just the efficiencies, the affordability, and as much as your point about an MA, you get more if you pay more, but that at the same time, there's savings that seniors get on average over $3,500 that they don't get in fee-for-service that they get by being in Medicare Advantage. So there is a key affordability issue, and sort of going to another direction here, when we have over half of seniors not just choosing MA over fee-for-service, but they also have a 95% satisfaction rate in the program. So, and also, as we all know, in open enrollment, seniors choose MA. There's not a default into it, and so it's an intentional choice with either it's themselves or with caregivers or family.
It's funny you say that, because when we were working on the Affordable Care Act, and there were, estimates that Medicare Advantage would decline, and I never thought it would. I knew that the value proposition was there. I did think when the Medicare Modernization Act passed a few years before that, I wonder if that will challenge, now that seniors can get a prescription drug benefit without having to join a health plan, will that somehow challenge Medicare Advantage? It didn't. Didn't at all. In fact, it grew. So again, I think seniors get the value proposition.
Well, again, as we have the seniors who have been here today and hearing that panel, they can articulate in their own words for lots of different reasons that value proposition. And just zeroing in on that, and it can vary. You talked about benefits, the benefits that they get in MA and not fee-for-service, or if it's the affordability. But all of that happens when there's certain policy developments, changes in the administration or done by Congress. What policy levers do you feel have led to the seniors being able to get what they value in MA that we need to retain for the stability of the program? Because that's just, we can recognize that we need to improve the program, but in that same conversation we have with policymakers, we recognize, we just did this with a group of you with the CMS officials last month, we talked about the need for stability and not these ongoing changes, some of which were recent with the Biden administration, but also it's happening at the same time when there's the medical trends and high utilization. So just sort of coming back to what seniors are valuing, where they're getting the affordability, they're getting the benefits in MA, but what policy levers do we need to retain so that continues?
It's funny. You said this is a sort of back to the future moment, and it is a little bit, because when I joined CMS, we were having discussions. It was actually before the Balanced Budget Act was enacted, but Bruce Fladdick, my predecessor, was having discussions with a couple of plans about doing multi-year contracting, with the idea that the understanding that it needs to be stable and dependable. So I think policy changes, no matter how well-intentioned, that are sudden and seem out of nowhere, which is, I think how some of what happened, V28 might have seemed. And I wasn't involved in it. I wasn't involved, well, I guess I was on the board of Aetna at the time. It seemed sudden to us. Maybe there were plenty of people who knew, oh, this is coming. But the fact that it was that big of a change, originally proposed to happen so quickly, that's a bit hard. And as a business person, you then have to, figure out how to message that to your beneficiaries and your members. And I think that is very hard, and it becomes a message, especially when some of us are part of public companies, it becomes a message of instability, and is this program going to be, is the government a reliable partner? And that's not a good message. So somehow you and I were talking the other day about this. I've wondered whether there could be one thing we used to do a little bit, it isn't done as frequently as it should be probably, is negotiated rulemaking, where you would sit down over a period of time and work through, each side has some goals and work through what it would be together, as opposed to a big, so that everybody could kind of have some transparency about what the issues are, what's being worked on over a period of time, and a phase-in period that both sides could agree to if there need to be changes, so that it wouldn't be such a big up, down, all the time. I think that's a problem for seniors, because they get these different messages. I've even worried, I'm hopeful, today's the start of open enrollment. I'm very hopeful that you'll see the same success that you always do, but with all the language around the shutdown and health care, I've wondered a little bit, are seniors worried about that? Do they worry that this could affect their Medicare, which I don't think it ever will, but they could rightly be somewhat worried about that. That's not a good thing either.
No, and you're right about the timing, and just already open enrollment, we're trying to make improvements. There's that complexity you talked about with Dr. Oz, but just that, the up, down. And we're also realizing, because of policy changes in that up, down, that seniors are facing increase in out-of-pocket costs. They are seeing plan closures that do ultimately have an impact on access. Again, there could be still choices for other plans in sort of their area, but sometimes it's just not for a senior, especially aging senior, geographically. That just may not be in the proximity that helps them.
I went through this. You may not remember it, but when Medicare Plus Choice first came in, and I hope, I was teasing you all about no one remembers this, but I hope there are some people on the Hill who remember it, because I certainly do. They proposed changes, well-intentioned, to and this was the very early days of risk adjustment, so it was very primitive still. But they wanted more plans in suburban and rural areas. They wanted, and in part because the chairman of the Senate Finance Committee, I think, or maybe the ranking, I guess he was the ranking person, was from a rural state, and they didn't have Medicare health plans, and so his seniors had no access to prescription drugs unless they got it through the Medigap plan, and that was very expensive, so he wanted that. But they did it in a budget neutral way, because this was part of the Balanced Budget Act that, cut the Medicare, extended the Medicare Trust Fund, but cut a lot of money out of Medicare, the largest cuts in Medicare, I think, in history. So they did it budget neutral, which meant they put in these floors for rural areas and ceilings on the urban areas. Well, the urban areas were where we already had some Medicare health plans. So plans pulled out of a lot of the areas they were in, the counties they were in. And I mean, I still have among the, 5 of the 10 worst phone calls I've ever had were from members of Congress during that time period, because the health plans were pulling out of their area. So we've seen this movie, and honestly, I was shocked that I'm glad there was a bit of a more of a glide path to V28, but I was a little surprised and called a Republican friend during the time period of the V28 proposal to say, am I missing something? Because back in the day, if there were concerns about health plans pulling out, this wouldn't be going forward. We'd be figuring out a plan B. And is it no longer that way for Medicare anymore? And this person said, yeah, I think things have changed. It's kind of surprising to me. So my idea for you is take this panel or a version of this in different parts of the country. Take it, have this group of people in Austin, Texas, and in other places to kind of make the case so that they understand what a huge benefit they're getting.
Right. No, that's we'll take it on the road.
I mean, I've just been a little bit surprised.
Well, and again, in that up-down that you referred to, so there's the plan closures that seniors, are facing, and then the increase out-of-pocket costs, and then change in benefits or loss of benefits, and all that affecting when they're looking to choose MA as their program at Medicare Advantage as their program of choice. But that said, we recognize the need for accountability and transparency. So how do we strike that balance of working with the regulators, you having been in this role, of problem solving on where we feel we need to be accountable and transparent? We've mentioned our support for the auditing plan every year. We've supported provider directors. There's so much we're supporting. But how do we continue on that path while still trying to protect the cuts to the program that sort of do that up down to seniors?
Yeah, well, I think the Better Medicare Alliance is standing up for the proposal to audit plans, being a part of that, being part of the solution. I think that's very important. I'm sure Dr. Oz appreciated that, and it's a shame that that's been, I guess, stymied. I suppose there must be appealing that, and maybe they'll go forward with it. I think this, as an observer now, the damaging things are the stories where it appears that plans are coding for conditions that then aren't treated. And I think you heard him say, if it's something that you're going to be treating for, you're going to be managing, fine. But if it's something that is not something you can really do anything about, or you're just adding it on, that's not fair. And I think the one thing I would challenge him on is, well, might not be something you're treating them on today, but it might be something that you think they will need to be treated for. And if I'm a business who has to have the money to provide you with care, because that's what I signed up for, then I need to have the money in the bank, or I need to have the ability to make sure I can pay for that. So somehow the two sides need to understand, the plans don't have the trust fund. They're signing up to manage this person's care in a way that is pretty open-ended, and provide a cap on expenses and everything for seniors. So if you're going to make changes in how they can code and what they can take account of in getting their payments, then you also have to accept that they're going to have to cut back on benefits. You can't do both. You can't. You're exposing yourself and your business to too much risk if you do that. So there just needs to be more, I think, discussion around what do you really expect out of plans? Do you like what they're providing? Because I think the basic construct of allowing the plans to bid and then having a benchmark, maybe the benchmark shouldn't just be fee for service as it exists right now. I mean, there have been some who've argued, including some in our industry, some in the Medicare Advantage or insurance industry have argued, well, given that Medicare Advantage is now so big, does it really make sense to be looking at fee-for-service enrollees in some of these counties? Is that really what we should be using as the way that we construct the benchmark? But anyway, I assume there's a fair way to come up with the benchmark, and then let the plans bid, knowing their costs, knowing knowing the benefits they're going to offer, and then the difference being partly a rebate, which increases the affordability, the premiums being lower, and part of it is a profit. I think that was a genius way to do this. So if we can all agree that construct makes sense, then maybe what we should be focusing on is the benchmark. Do we agree that the benchmark is the fair benchmark? Do we agree that the amount of rebate is fair? And if we can come to agreement on those things, then you look at it and say, can we still provide these benefits? I hope that that's the case. But coding has to be a part of it. You have to be able to say, I'm not an actuary, but I've worked with enough of them. I would never go into this business without knowing who are these people that I'm supposed to be taking care of. No one would do that.
And what am I treating?
What am I treating? Yeah. What should I be treating? What am I hoping to help them get better with? What preventive benefits should I even be offering? You have to know that. So somewhere I think coding has become the villain, in part because of some of those stories, as I said, that made it appear that plans were coding just for the sake of coding. Dr. Oz had a term for it, was it? It was clever. I've heard him say it before, he wants to make coding like a commodity or like something that doesn't matter, because it really shouldn't matter in how you take care of patients. And I know what he's saying, but he's looking at it, I think, as a provider and as a clinician, former clinician, which he is, and I'm grateful for his service in that way and his thinking in that way. But as a business, you have to be looking at how much will it cost to provide this member what I've signed up to provide them. Can I do it? And for that, you need to know all the facts and all the numbers you can know, and then you need to try to take care of them, for sure. You don't need to like not do anything
not
and have
do it at all.
Just be sitting at home, but yeah. So I think this problem is there have been some stories that, as we all know, anecdotes don't make good policy, and unfortunately that's happened.
One of Medicare Advantage's success stories is who we're serving, and fortunately more and more seniors who are low income or in diverse communities are continually signing up for Medicare Advantage, and obviously that is helping address access issues for those populations. What more do you think, knowing what you know of Medicare Advantage, Nancy, and we can be doing to address those gaps and ensure that we're retaining coverage for those populations?
Well, meeting them in the communities where they are. And I've seen some of what your members have been doing in their communities, reaching out. Another innovation that Plan started was the culture, what we now call cultural competency, or the different languages that are spoken, and tailoring plans to certain populations, offering some benefits to be covered that those populations are more interested in. All of those things are innovations that I think can help connect with those beneficiaries who may be lower income, who may have had struggles getting to the right kind of provider who can speak their language, and you can help navigate them to get the care that they need. So I think the innovations are there, and if I were looking for a playbook, I would look through there's something on your website actually that has a list of some of the things that plans have done. That's what I would go through and figure out which ones I could do. That's the way to reach people, I think.
Again,
one thing you've been criticized for,
yeah.
But let's make an advantage out of it, is marketing. You're good at that. So you have the experts and the expertise to figure out how to engage people, how to really, Dr. Oz said something like, I don't want to pay you for engagement. I know what he means about that, but it does start with engagement. It starts with getting someone interested. Why do you think those 4 people were here today? They were here because they feel like their health plan connected with them and cares about them and is helping them. And that's how you address some of the social determinants of health. You don't address that until you engage the member or the customer. So you guys are good at that, and you could help. Frankly, you could help fee-for-service. I think there are things. Remember how pitiful it was that our fee-for-service marketing budget was so little. We run a few PSAs every year. That's not going to cut it, right? I mean, so maybe they could take a page out of your playbook.
This is a forward-looking question, and maybe one that we can look at as our last question going in, but it's going to be somewhat sort of looking in the present, but looking to the future. So currently, with the administration that's in place, it's very critical times to meeting the needs of seniors, especially with changes in the economy and the rising cost of health care on the economic side, but still needing to make sure that we're doing all we can on preventive health. With all the work that you've done, both in directly in the plans, in your role at Consonance Capital, but then also in the state government, the federal government, just over the span of that time, how do you view how the administration is approaching, and it's obviously CMS in Medicare and Medicare Advantage, but then also at the same time looking ahead, what makes you optimistic about how in these challenging times we can still be in a place of delivering the care that seniors need?
Well, I think when I look at CMS, I think there have been a lot of changes this year that have been troubling in the government writ large, but at CMS, I give Dr. Oz credit. I think it's been pretty stable. I think from talking to people that I know who either have been there or are still there, that they feel valued. The cuts have been less there. I think we need. I know there are people in this room who've worked there or worked with CMS. We need smart people on the other side of the table helping to lead these programs. This is not something any of us can do by ourselves. So I'm hopeful about that. I'm hopeful about Dr. Oz's approach. He's thoughtful. He's a clinician first, which is always a good sign. Of someone who understands what it's like to take care of patients. I think that is a good sign. And I think that they've been trying to send a signal of stability. And the fact that he came today is an example. You and I talked about this. There have been shutdowns where government officials don't go anywhere. In fact, sometimes that's the rule. And I have a feeling he probably stretched to be able to come to this because this is an important audience for him. You're taking care of more than half of the Medicare beneficiaries in the country. That's an important responsibility, and he knows he's depending on you. So I think that's a good sign. I'm hopeful about that. The other thing that makes me hopeful is the people we heard from right before this, the seniors who, again, if I contrast them with the groups that I used to meet with when I was going on the road those years ago in the Clinton administration, they're healthier, they seem happier, they seem to feel like their benefits are more affordable. And I think that's because of the work that people in this room have done. So I think at this point, with half or more than half of beneficiaries in Medicare Advantage, it deserves really thoughtful conversation before anyone does anything drastic to it. What exactly is broken here? And I think you'd have to say the affordability for, if you start with the beneficiary, their affordability is not broken. In fact, it's been improved. Their ability to get the services they need is improved. Innovation is part of it. So what is it that you want to fix? And if what you want to fix is the cost, well, let's talk about that. As you said, how do we preserve what's been created here that's so beneficial and make sure that it's manageable? And looking toward the future, I do get worried when I see the Medicare Trust Fund insolvency, not because it is truly that meaningful in a way, because it's the Hospital Insurance Trust Fund. We know Medicare is not going to go bankrupt. We know that the country has the money for it. But I hear politicians saying things like, it's just unsustainable, we can't afford it. And sometimes that leads to discussions that involve cutting everything, in a not very thoughtful way. So that worries me out there in the future, and I think this organization should be focused on what's our solution to that. Because you care about the program and it being there for all of our relatives as well as your members now, and avoiding the scary conversation in 3 or 4 years when it'll be one of those conversations, we have to cut everything, So in your spare time, after you do the road show with your members, that's something I think that you guys should be thinking about. How do we play in that discussion, even though it's about the Hospital Insurance Trust Fund? How do we, put some good ideas on the table, work with other groups in our industry, providers and other groups to figure out what is best for seniors, what is best for this program.
Thank you, Nancy Ann, and thank you so much for sharing your knowledge, regardless of what hat you're wearing in your career, to just be able to be a leading national voice in health policy. We'll all be better for it, and thank you for some of the ideas and homework that you've given me to take back.
I'm always good at that.
But thanks so much.
Thank you.